Evening to everyone. This is the 18th session of the Learn from the Masters series that we have at ASG, where we bring in the experts on various topics who basically share their insights regarding the details of the nitty-gritties of a particular topic of clinical importance for us. We designed this in a way that one of the experts can give a didactic lecture covering all the aspects and the nuances. And we also have a very important role for the panelists who are equally important in, driving the message forward and bringing out the most important aspects of those topics through their discussions. So today we have Dr. Jay Kelkar, but first I'll introduce the panelists to the audience. Dr. Kavita, ma'am is a consultant in pediatric ophthalmology at Shankar Eye Hospital in Shivamogga. She is a very renowned ophthalmologist with degrees and fellowships from international universities, the International Council of Ophthalmology, UK. She has done a short-term observership in AIMS in the strabismus unit. She is also honored with the MCH in ophthalmology from Seychelles, and she is a regular reviewer of many peer-reviewed journals. Her areas of interest are pediatric ophthalmology, adult cataract, low vision aids, neuro-ophthalmology, bioethics and research and teaching. She has won multiple awards, including the Best Video Award, the Best Pediatric Paper Awards at multiple occasions in the Karnataka Ophthalmic Society, Indian Ophthalmic Society, and so on. Currently, she is the editor of the Karnataka Ophthalmic State Journal. She is a teacher par excellence and has won multiple accolades for her teaching and clinical acumen. Welcome, ma'am. Next, we have Dr. Anand sir, who is a senior phaco-refractive surgeon and assistant medical director at Lotus Eye Hospitals. Sir has more than 15 years of experience in ophthalmology, though if you will talk to him, you will realize that it seems more like 50 years of experience in ophthalmology because of the tremendous volume of work that he has under his belt. He has trained directly under the chairman of Lotus Eye Hospitals, Dr. S.K. Sundaramurthy, and he is a prolific cataract and refractive surgeon, having done more than 3,500 C3Rs. That is something that is shocking and surprising to know the kind of work that he has been doing. He has multiple international awards to his credit. He was awarded the Young Ophthalmologist Award in Portugal in 2017 at ESCRS, CME Award at Vienna in Austria, ICL 500 Award, of course, because of the high volumes of surgeries he does. He has a tremendous experience in phakic lenses as well. And he's a renowned speaker at multiple state, national, and international platforms. I had the recent good fortune of meeting him at the recent Uttar Pradesh Ophthalmic Society conference as well. Welcome, sir. And I would hand over to Dr. Ashwini to introduce Dr. Soumya, ma'am.
Thank you, Prakash. Before starting with the Soumya ma'am, I'll just add a few words for Anand sir. Anand sir was my teacher. So I've seen Anand sir training and the way he's trained all fellows, students. And Sunday is no Sunday. Sunday means 10 LASIK, 5 smiles, 10 cataract surgeries. Means he hardly take off. I've seen him working 365 days. Off means no off. Morning you'll get a message to you. This today so many surgeries are there. You have to be there. I did my thesis under sir for smile, and that time he gave me students so many smile surgery to do. I was like, people don't give any. He gives very free hand, very good in teaching and training, one-to-one mentorship he gives. Thanks, sir. And sir,
Yes,
now
Sachin. Thank you.
I go to Soumya ma'am. Soumya ma'am. Thank you, ma'am. I'm very great pleasure to me to introduce Dr. Soumya Ganesh Naya, ma'am. Ma'am is a dynamic teacher in ophthalmology and a current managing director and consultant at the Lopamutra District Hospitals and its associate centers in Kodagu. It's in one of the famous area. If you go to Mysore, you have to go to Kodaikanal, Uti. The Uti मैं क्या बोल रहा हूँ, सॉरी फॉर दैट। डॉक्टर सौम्या completed her MBBS from Bangalore Medical College and her postgraduate training from prestigious Mysore Medical College, followed by her fellowship in cataract surgery at Narayan Nethralaya. Ma'am was award-winning academic and surgeon, having earned acknowledged the World Ophthalmic Congress in South Africa, APO in Singapore, and ESCRS in Amsterdam, and multiple AOS conferences. In 2024, she was named as Ophthalmic Entrepreneur of the Year by Women Ophthalmic Society. Ma'am has also authored many textbook chapters, contributed to peer-reviewed journals, and sought after speaker globally. Ma'am has performed the first Kurvu ICL and several surgeries and led her institute to become the first NABH accredited institute in region. Welcome, ma'am, for joining us for this discussion. And other than this thing, as I know, ma'am has like all other than surgeries and teaching, ma'am had great interest in meditation and way to live life as a surgeon. And I have learned a lot from ma'am from I think from 2011 onwards. So ma'am was which something which is not in mentioned in the anywhere. Ma'am was famous in Mysore. Ma'am was a teacher from that time to teach students DNBs. Ma'am is a RJ if I'm allowed to say. Ma'am was famous singer that time also. Welcome you, ma'am.
Thank you so much, Dr.
And
Ashwini, for this very kind introduction. Thank you.
still remember like how great you are from the Mysore time, and we never
Thank
thought,
you so
ma'am.
much.
And this
Thank
time,
you.
AOS, your ma'am, talks are always on the life, how to live the life as a surgeon, doctor, and to de-stress ourselves. And
Yes,
then,
definitely.
and
Thank you so much. Thank you.
thank you. Next, I'm going to welcome Zai ma'am. Uh, Zai ma'am, other than this, as all of us knows something which people might not know, ma'am is a marathon runner, marathon winner. She every year goes to marathons. Ma'am and Sir Jay sir both. So, ma'am is the medical director of NIO Institute Pune. Ma'am has done her DNB from Pune in 2004. Then FRCS glaucoma, FACS from USA, FRCO from London, ICO fellowships in pediatric ophthalmology from US, Ghent, and Belgium. Ma'am has done 15,000 surgeries. Ma'am has trained more than 30 postgrad fellows and surgeons. The ma'am has invited a speaker, live surgeries in multiple international states. Ma'am has authored a book, I Care for Kids. Ma'am have more than 45 publications in reviewed journals and editor in IJO. And ma'am was the president of Pune Society. Ma'am is awarded with International Hero Award in AIUS in 2022 and 24, and Best Paper Award in APO in 2024, Achievement Award APO 2021, and Gold Award in Indian Journal of Ophthalmology in 2018. Welcome you, ma'am. Zai, ma'am.
I think with this introduction, we can start with ma'am's class right away,
Yes.
and then we can
So,
have a good discussion.
Yeah, so thank you very much, Dr. Ashwini. It is nice to see you online because it's been a long time since we met. And thanks for the kind introduction. And thank you very much for this opportunity. I've tried to do as much justice as I could to the topic, but it's a vast topic and it's still evolving because every day we are learning new things about it. But I hope this helps.
ma'am, it will help, ma'am. We've seen you targeting dot 66, dot N6, and getting screwed if it's 0.5 also there and there. So we know, ma'am, you will be the best to this topic,
At
ma'am.
least I know that Dr. Ashwin Kumar is very, you can say, generous with his praise, but yes, thank you so much. Okay, so I'll start.
Yes, please, ma'am.
My slide is visible, isn't it? Yeah, can you all see my slide?
Yes, ma'am, it's visible.
Okay.
Please.
So, what do patients want these days? So, cataract surgery is now a refractive procedure, and freedom from glasses or customization of the post-op refractive error is the standard of care. All patients want near perfect visual outcomes, and they are not ready to negotiate on that. So, be it a small child, an irregular cornea, vitrectomized eye, or simply a young professional, patients don't care what their pre-op considerations are, and they want the best result where cataract surgery is concerned. So, this necessitates a highly accurate calculation of the IOL power. But then there are difficult situations, and how do we navigate them? This is something that I'll try to explain in this lecture. So, how did the IOL power calculations evolve? There have been two major formulae. These fall in two categories. That's the regression formula and the versions formula. Yeah. The regressions formula were based on the mathematical and statistical analysis, and the versions formula included more variables like the net corneal power, the axial length, the IOL power, effective lens position, the desired refraction, and the vertex distance. So therefore, the accuracy now depends on how accurate biometry you are able to perform. So based on these variables, the IR formulae got divided into four generations. The first generation being the SRK and the Binghorst, the second being the SRK2, then came the SRK-T, Hoffer-Q, Holiday, and the fourth generation Holiday 2, Haggis and Olsen. So first generation formulae were based on axial length and keratometry. SRK formula, which we all learned in the PG days, was the gold standard for a long time. And this introduced the concept of lens specific constant and considering the design and position of the IOL. And this was the first regression formula. The first generation formulae were quite accurate in regular eyes, but the formula needed to be adjusted when the axial length was either very small or very large, that's in high myopes or high hypermetropes. The Hoffer-Q adjustment was made for the ACD and the modified Binghorst formula used the measured axial length. These formulae were termed as the second generation. The SRK2 was developed by adding a C value to the original SRK formula. So what is this C value? It is determined through the regression analysis of the post-operative refraction error data. So depending on the axial length, they gave you corrections. So if the axial length ranged from 10 to 20 millimeters, then what is the C value? So accordingly, based on the axial length, they gave the correction factors. As patients still had residual refractive error, even after use of second generation formula, researchers kept on studying the relationship between the IOL power, the axial length, and the corneal curvature. And they came by after merging several parameters like the pseudophakic ACD, the surgeon factor, and the A constant. These three formulae, the Hoffer-Q, Holiday 1, and SRK-T, came into being. The third generation Formula 2 were good but needed refinement. More studies were being conducted incorporating patient parameters to decrease the post-operative refractive errors. So two factors came into being, that is the ELP and the surgeon factor. So what are those? So ELP is the effective lens position and it is the distance between the anterior surface of the cornea and the plane of IOL, assuming that the IOL is a thin lens. It refers to the predicted location of the intraocular lens relative to the cornea, essentially the distance between the cornea surface and the IOL's position within the eye. The accurate prediction of the LP is essential for achieving the desired vision correction after cataract surgery. So this is the basis for adding this parameter into the formula. And what is the surgeon factor? The distance from the postoperative anterior iris plane to the effective optical plane of the IOL. So this factor is crucial for accurate power calculation because it helps us to predict the ELP, which is not directly measurable before surgery. So Halliday's work highlighted that assuming a relationship between the axial length and the anterior chamber depth, and therefore the ELP was not always accurate. Therefore, they needed a personalization of the constants like the surgeon factor because every surgeon will be using a different lens, will be placing the lens differently, and this is all going. Fourth generation formula were introduced, which let's consider the first one, which is the Haggis formula, which introduced three A constants. All the three A constants can be personalized to refine the IOL power. So it, along with the personalized A constant, it uses the axial length keratometry and the anterior chamber depth. It is very suitable for post-refractive surgery patients and patients with irregular corneal astigmatism. However, it can be inaccurate for extremely short or long eyes. But then there are other formulae to tackle those eyes. The Holiday formula introduced seven variables in IR power calculation. Along with axial length K reading, it also included the pre-op refractive error, the white-to-white measurement, lens thickness, patient's age, and the anterior chamber depth. The Barrett's formula, which is based on the model eye, it combined axial length, keratometry, and ACD with regression analysis. And it incorporated the final plane of the position of the IOL, increasing its accuracy. And it is accurate for a wide range of cases like post-refractive surgery, keratoconus. And of course, it gives you adjustments also which need to be done for certain corneal shapes because even an irregular cornea may not be regularly irregular, but several other irregularities also can be detected. The SRK2 formula was updated from the SRK-T formula by regression analysis and postoperative outcomes. So it led to a significant decrease in errors. The SRK2 formula was P is equal to A1 minus 0.9 K minus 2.5 AL. We all know what P, A, and K and L stands for. But adjustments to the A constants were based on the axial length, and this helped in getting accurate results for the post surgery refractive errors. For high myopes, Wang and Koch adjustment has been suggested for some third and fourth generation formula to optimize the calculation for axial lengths which are more than 25 millimeters. Again, there are newer power techniques that have evolved, like the ray tracing method and the heel radial basis function, the RBF. So both combine AI with regression analysis of a large post-surgical patient to calculate the IOL power. And it can learn from large data sets and adapt to the complex cases, but it definitely still requires computational resources and data. So you have to keep going back to your cases and seeing in case you get refractive surprises despite using all these formulae. The Kane formula and the Ladas formula are they combine artificial intelligence with the theoretical optics of the eye for IOL power calculation, and the Ladas formula is known as the super formula. It automatically chooses the most appropriate formula according to the patient's axial length and corneal power. The formula incorporated are the SRKT, Hoffer Q, Holiday 1 and Holiday with WK adjustments and the Higgins. So when you're choosing a formula, you consider the patient's specific ocular characteristics, the surgeon's experience and preference, also what the patient desires, the post-op refraction that the patient desires, and the availability of advanced technologies and computational resources. So coming to that, first thing that comes to our mind is biometry, because there are machines which are going to help us do that. I've just made a short one single slide telling us what currently is available in the market and what principle they are used on. This is all physics, and so I didn't want to go much into it because not even relevant to our topic, but we should be knowing what is available and what each machine is offering us in terms of dial power calculation. The most commonly used and most versatile of the machine of all the machines is the IOL Master 700, and it is based on the swept source OCT technology. It has a scan speed of 2000 scans per second, and the OCT scans the images the fovea, which allows the clinician to decide if the fixation is central. It can measure both the anterior and the posterior corneal curvatures and take measurements in dense cataracts as well as opaque media. All the modern IOL power calculation formula, including the Barrett suite consisting of the Barrett Universal 2, Barrett's True K, and the Barrett Toric, are also available, and it can also link with the Caliso system for Toric IOL implantation. So let us consider what are the difficult situations and how are we going to proceed in these situations. So first of all, before we decide, there are some prerequisites for biometry. First being, is there a history of contact lenses? If the patient is wearing contact lenses, definitely ask them to remove them 3 days prior if it's a soft contact lens, at least a month if it's a gas permeable lens, and if it's a toric, at least 1 week prior. Rule out ocular surface disease. Meibomian gland dysfunction can alter the corneal epithelium and the surface and give you false readings like astigmatism or ectasia, picture of ectasia when there is none. So meibomian gland dysfunction should be ruled out. Punctate keratitis, dry eyes should be adequately treated. Is there any history of previous surgery, like any retinal surgery or any corneal surface surgery or a previously operated pterygium? And like in always, in every case, rule out trauma. So for cases with high astigmatism, ectasia, irregular cornea, post-RK, we have the toric lens calculation, which includes the posterior corneal astigmatism. So examining that or including the posterior corneal astigmatism is most important, because if you ignore the with the rule astigmatism, that can lead to overcorrection. Against the rule can give rise to undercorrection. So the Barrett's True K toric calculator comes to help in this situation. And as you can see in the slide, you can enter all the parameters from the flat K to the steep K with a huge range of 30 to 60 diopters. And then you have to also give the history of whether LASIK with a drop box with myopic LASIK versus myopic correction, whether it was a hyperopic procedure. Again, axial length, you have to tell the optical ACD, and you have to write the target refraction. The surgeon-induced astigmatism also is very important, and that has been incorporated, and the location of the incision. Radial keratotomy, nowadays we are seeing many patients with RK who have had RK in the past and now developing cataracts. So you cannot never promise an emmetropic or a zero number or a plano glass after the surgery, but you can at least aim for -1 or -2 depending on the cuts on the cornea. These patients may give you a very good picture of being 6/6 or 6/9 on day 1 of surgery. But as the cuts start to heal, as the wound starts to heal, you can have refractive surprises coming in later on, that is after 8 days or 15 days post-operative. Again, you have to enter as per the chart shown, and then it will give you all the idea. And if you have this integrated with your microscope, the toric placement also becomes very accurate. In cases of irregular corneas, so be sure that you have a corneal topography done, and the tangential anterior map is the most important, which will show you the region of the maximum ectasia and whether it lies in the central 3 millimeter, 3.5 millimeter zone, whether if it's a post refractive surgery ectasia, you will come to know about the optical zone that was chosen during the procedure. And when you calculate, you will have to also enter into that the effective corneal power cannot be predicted. You have to understand. Therefore, you have to take at least 3 readings. And if it is possible, and if the corneal pachymetry allows you, topo-guided surface ablation for a stable topography prior to cataract surgery has been recommended and gives very good quality of vision in those patients who have a very irregular surface where toric lens may not cover that stigmatism. Cases of dense cataract also pose a challenge because you are at times unable to find out the exact axial length. If the exact axial length is not obtained, obviously we were either going to over predict or under predict the IOL power. Because of the dense nature of the placement of the lenticular fibers, as you can see on the anterior segment OCT pictures here, it is difficult to gauge whether the readings that you are getting are of the exact axial length or not. So therefore, check the SN ratio. SN ratio should be less than 2. SN ratio is the signal to noise ratio, which is a measure of reliability of the axial length measurements taken by the IOL master. So it indicates the strength of the optical signal received from the eye relative to the background noise, and a higher SN ratio signifies a more accurate measurement. Again, the standard deviation between the measurements should not be more than 0.2. For cases with high myopia, the selection of IOL formula for high myopic patients, Haggis or SRK-T, would reduce the prediction error and serve as a more accurate formula than Holiday 1. Again, Haggis formula may be more accurate than the SRK-T formula in cases of axial length more than 30 millimeters or keratometry less than 43. So there are several are papers published in literature about the adjustment, and various ways are being tried the world over where you can compare the accuracy of several formula, and you can even try different modifications to get the exact owl power. So overall, in high myopia, more preferred are the Holiday 2, Barrett Universal, and the Hill RBF. If you're using the second generation or the third generation formula, they have a tendency to cause a hyperopic refractive error. So this is how the IL power scan would look like. And when you're using the SRK2 or the SRK-T, sorry, you can see it will give you the expected refractive error post-operative. And accordingly, you can even select if you want to choose the first minus or the first plus, depending on the patient's requirement and the surgeon's choice. This is how the calculation, if done through the Barrett Universal 2 formula, would look like. And they would also tell us whether the type of lens is biconvex or meniscus lens. Depending on that, how much IOL power you want to choose, what post-op refraction you are going to get. In high hypermetropes, that is the short eyes, greater is the error because smaller the eye, greater the error. So compare the axial length with the optical and the immersion method. And the formula of choice here will be Haggis and Hoffer-Q. Very easy to remember that hyperopia H, so therefore Haggis or Hoffer-Q. Cases of corneal opacity also pose a challenge because of the opacity. The errors in measurement of the axial length are very, very common. Again, you can underestimate or even overestimate the astigmatism, the postoperative astigmatism that can come. Usually, you get definite, relatively, I would say, or pretty accurate measurements if you use these formula. And then you also have the choice of lenses, different lenses that can be used for such a situation, and what is the predicted postoperative outcome. The patients with aphakia require a special mention because certain changes in the IOL measurements have to be done. The parameter altered is the speed of travel of sound, which now averages 1532 meters per second. Also, in ultrasound biometry, two lens spikes in A scan are absent, and they're replaced by a single spike of the anterior vitreous phase and the posterior capsule. So here the immersion method is preferred rather than the contact method. The newer devices like the IOL Master 700 have specifically programmed modes for aphakia. So they have made our life really easy. And most of the values will remain similar in the theoretical equations, except the manufacturer's ACD. As the manufacturer's ACD is for in the bag placement, unless specific lenses are utilized, you don't have to make changes for that. So formulas like the Barrett Universal 2 or Olson are frequently used and they are most accurate for aphakic eyes. So it is how you get, and you can write whether the patient has a aphakia, it is phakic, it is a vitrectomized, whatever, all the options are there. And then accordingly, you can, as you choose it on the computer, accordingly the machine will compute the lens. For the pediatric age group, there are different problems because first comes with inaccurate measurements in actual length because often children will not cooperate. Inaccurate measurements of keratometry. So whenever it is possible, a handheld keratometer definitely helps in getting the keratometry values correct. If the resources are available, examination under anesthesia for the IOL power measurements is the most accurate way to go about it. And the IOL power chosen should allow for good vision in the growing age to prevent amblyopia, and it also ideally should give emmetropia in adult age. So all calculations will be based on the age of the child and how the myopic shift will occur in the eye, so that the patient becomes emmetrope by the time they reach 18 years of age. So currently, all infants above 2 years are advised IOL worldwide, while there are some differences in opinion about children who are less than 2 years of age, bilateral myopes. If it's bilateral cataracts, if it's unilateral, usually a lens implantation is a good idea. The development of the eye necessitates initial undercorrection because there is definitely going to be a myopic shift. There are several, again, formulas, ways to go about it. But the most commonly used formula for pediatric patients who are, so you cannot take them for examination under anesthesia, or you're not very sure about the keratometry values, then Dahan formula helps a lot, especially for undercorrection in pediatric cataract surgery. So it aims to predict the long-term refractive status of the eye after surgery and takes into account factors like the axial length and keratometry. And the actual length measurements are done by B-scan ultrasonography. So once you take the measurements, re-verify them, preferably from the optometrist has done it, then even it's worthwhile for you to go and verify them. And then depending upon the age of the child to decide on the undercorrection. If it's 2 years, 2 to 6 years, 6 to 10 years, accordingly undercorrections are done. Again, also you have undercorrections based on the axial length only if you do not have the keratometry values. Vasada et al. Have also suggested how much percentage of undercorrection should be taken. There is also a rule of seven, but personally, I have found that it gives a lot of undercorrection if you follow the rule of seven, especially in very young children. After posterior segment surgery, again, a challenging situation because the velocity of sound in silicone oil is slower than in vitreous, and that also gives rise to difficulties in measuring the actual length. So this is achieved after alteration of settings in the newer machines. Silicone oil in the eye itself acts as a negative lens. When a biconvex IOL is implanted, so the IOL power must be adjusted by 3 to 5 diopters. So measurement of axial and by optical method has found to be much more accurate for silicone filled eyes. Again, you have these options if it's a silicone filled eye, if it's a post-vitrectomized eye. Post and Barrett's 2 or also formula and even intraoperative aberrometry can be a tool for fine-tuning the results. So when you calculate with using the SRK-T formula, you get the entire menu here, which lens, how much post-operative refractive error can be. And when you calculate with the Barrett's, also you get the refractive error and what options that they are offering. After refractive surgery, again, a huge bunch of patients are coming who have had refractive surgery in the past. IOL power calculations are different because the spherical nature of the cornea is altered after the refractive surgery. And not only the central, but as well as the posterior corneal curvature, which is not routinely measured, needs to be taken into account. So these errors can occur due to instruments index of refraction and formula which are used. And remember that flatter the cornea, greater the measurement zone, and hence greater is the error. So the refractive index is based upon the ratio between the anterior and posterior corneal curvatures. The relationship between the curvatures is altered in PRK, LASIK, but avoided in RK, which causes alteration in curvatures such that the relationship is maintained. This overestimates the corneal power by 1 diopter for every 7 diopters of correction of refractive error. So it is very important to remember that. So get a good topography done. Once you have the topography, you can enter the values in the IOL master or your biometer. and you will get the results. But be sure that you have an accurate topography before you do this. And again, you have options, whether it's a post-RK eye, whether it's a high myopic eye, LASIK has been done. All these options are possible in the Barrett's as well as in the SRKT formula, and you can then go ahead with the planning. So to measure the IOL post-refractive surgery, it can be divided as indirect or direct methods. So indirect is the clinical history method or the calculation method or the contact lens over refraction method, the DBR method, which is commonly used, or the direct will be, which are not much used, but topography method is one of the commonly used method. So what are the major sources of prediction error for the IOL power? In prediction of ELP, you can go 35% wrong. Axial length measure can give rise to 17%. Keratometry measurements 10%, but post-op refraction 27%, which is a whopping comes to the second place. And what are the reasons why you can have these problems? It can be acts of commission and acts of emission. If the person who was doing the keratometry, the IOL power measurement was in a hurry, they're relying too much upon their assistants, their incorrect eye, incorrect patient, incorrect biometry print, incorrect labeling of IOL. So these are all human errors, or there can be no biometry at all, no spectacle prescription, incorrect no IOL or incorrect IOL on the day of surgery. All the nightmares which need to be looked in one day prior or a day prior to the procedure. There can be faulty measurements of the axial length because of excessive indentation, or the probe is not held perpendicular, inappropriate equipment calibration. Then measurement of K, surgical errors, and again choosing the inappropriate formula. That can be you have all the armamentarium, but you choose the incorrect formula, then all is lost. Sometimes simple errors like making an incorrect entry or making rarely instrument error because machine is not calibrated. You are not checking the steeper axis before the incision, not altering um, the constants as per the surgical results. All these can give rise to common reasons for failure.
Uh, I
Ma'am,
think we certainly, I think ma'am has just dropped out. Uh, I can't see. Yes, ma'am has just dropped out. I think, Srini sir, can you contact her and ask? Meanwhile, I have some questions from what we've already covered. So if we talk about, is she
ma'am
back?
will come back in 2 minutes.
Yeah. So if my question is, if we have a post-RK patient, then is the method of choice from all the panelists right now? Uh, Soumya
Yes.
ma'am, you can unmute yourself, please. And yeah, you can start.
I see Dr. Anand also wanted to say something, but I think post RK, what we must remember is how it is different from LASIK is that in post LASIK, there's a difference or flattening in the anterior surface of the cornea, whereas in post RK, there's flattening both in anterior and posterior. So that is the basic difference, and there is a mid peripheral steepening in post RK. And I think Barrett calculator is fantastic. That way, it has solved so much of our problems in the sense that you can enter readings you have and it will give you the best possible result compared to most formulas. So I would go with the Barrett's formula. But another thing that we must remember with post RK is that there is going to be a change in refraction as the wound heals because the we don't know how much of stress the incisions have taken during the cataract surgery. So within the next 15 days to a month, we can expect a change in refraction that is different from the first day result as well. So I think it's very important to counsel the patient regarding this prior. And just like in post LASIK, although in post LASIK now with the IOL Master 700, I think we're getting pretty good results. But also, what we must remember is that in post RK, we would like to go slightly more myopic when we choose the IOL because there is a chance of hyperopic surprise later on.
Yes, I totally agree with what Soumya told. That's what I wanted to say. It's always the question of stability when it comes to RK. The key home points is target myopia because there can be hyperopic shift. Present EVL formulas because I have experience of operating more than 100 patients of RK in last year. Use Barrett Truque or Haggis and target myopia and tackle the intraoperative problems. You'll be able to achieve the targeted result.
Is there a relation you would keep between the number of cuts and the amount of myopia that you are aiming for, like the amount of overcorrection that you are going to do?
Frankly, no.
Okay. Any comments from Kavita ma'am on her experience with
No,
such kind of
I'm not
patients?
a refractive surgeon actually. I'm a pediatric surgeon. But I think I read somewhere that even the number of cuts, I think we have to keep in mind. Probably the way it gets flattened out. I think how you consider the K reading now, whether only the is an average or anterior curvature as well as posterior curvature, how that is what I can think about. Because I mean, me, I'm quite old, and this oil formula and other things, no, it has evolved like literally with us. So that's why I'm thinking, though I'm not a refractive surgeon and operating on cataracts with post RK or anything, I have little knowledge on that. I think the way you are considering the care reading and also the number of cuts, I think it should matter.
Okay. Ma'am, regarding, okay, I think ma'am is back. We can continue with her talk and then we can take the remaining doubts that we have. Please continue, ma'am.
आप ऑडिबल नहीं है.
Ma'am, we can see your screen, but you're not audible.
Yeah. Yes. Yes. So the pulse for success will be no other contact procedure before the keratometry. Use topical anesthesia before the scan. Calibrate the keratometer before the scan. Take an average of 3 readings. If there is a discrepancy, always ask the second person to cross check. Compare the refraction, especially with the axis and the K values, and repeat if there is a difference of more than 1 diopters between the two eyes. Each surgeon must review their own results and appropriately make alterations to the biometry if needed. Regular checks and audits are also a good habit. Training and monitoring of the staff is equally important. So while selecting the patient, ensure that the eye and the papers are in order and correspond to each other. Cross-checking with refraction is also a good idea if accurate retinoscopy is available. While performing the actual scan, ensure that asepsis, especially in contact procedures, is observed, and patient comfort and anesthesia should be monitored, and in no way should the patient comfort be compromised. Thank you. So was my last one. This is not moving.
Madam, I think we missed you in between. Can you please? Actually, you were not audible in between. So, can you please go back with the slide?
Now you want me to go back to the slides?
Yes, we want to see whether we missed anything in the okay.
Yeah. So it was I was just talking about the act of what are the sources of errors, and I think it was then that the computer switched off.
Yes, ma'am.
And after that, we come to the last slide, which they're the minor things, but very important that you should look for, so that even though you have the armamentarium and still don't end up making mistakes. And also for it is always better to document and be safe and cross check and do all the timeout procedures before you do any such an important procedure, which is the backbone of our practice, the cataract surgery. So thank you.
So, ma'am, we were discussing about post RKIs, and what we've understood to summarize is that we should
Hmm.
go with Barrett's,
Yes.
and with Barrett's, we should target second or third myopic. That
Yes.
is the power that we should be taking.
Hmm.
And basically, the day one post-operative result may not be the accurate result. So we
Yes.
should wait for about 15-20 days before we can conclude and say that this is going to be the stable
Exactly.
refractive outcome for the
Yes.
patient.
Because wound
And
healing is different in post RK patients.
right,
Sometimes one of the RK cuts may open up and you may even require to take a suture during the procedure.
right. My next question is, what is your take on toric IOLs in post-RK patients? Like,
We are publishing a paper based on our data for this. So we have very encouraging about 60% of patients are achieving less than zero point 0.5 cylinder with post RK with toric lenses. 40% we are still getting refractive surprises. So some people have got more than -1 cylindrical error, or some even have got zero point 0.7 plus 0.75 cylinder. But about
yes.
60% are less than zero point 0.5.
So, would it be like for normal eyes, we say that we are using toric IOL for say more than 1.25 or more than 1.5 delta K.
Hmm.
For post RK, the cutoff should remain the same, or would
No,
the
so for even
cutoff
for
be different?
regular eyes, these days we have, after listening to Dr. Ronaldo in one of the conferences, for anything more than 0.75 for even regular, those are not non-RK eyes also, we are recommending toric IOL
Okay. And for RK, also the same.
or RK because they have huge amounts.
From in their practice on this.
Yes. So I agree with Dr. Jai in the sense that for even for effectively. And another point I wanted to mention was in post LASIK corneas. So now we have fantastic equipment and formula, it's made our life so much simpler. If we were practicing post refractive cataracts 20, 30 years back, it was so much more complicated for us. But in post LASIK, I think when we use formulas, IOL Master SimK gives us very good results. And if you were to use pentacam readings for keratometry, it's important to note that you would need to use the EKR values and not direct pentacam readings in post LASIK corneas. And if you were to consider irregular corneas like keratoconus, then you should extend your EKR to about 4.5 millimeter zone, whereas in regular corneas, you can stick to 3 millimeter zone.
Uh, Next, we have a doubt. We have a case. If you would allow me to share my screen, we were just discussing that, we'll ask this doubt with you. So, so that we have a lot of fellows who have joined in. So we want that we should have some practical tips for them to take home. So if you can see my screen now, so basically this is the case that we have. And so the axial length is highly myopic. And the four formulae that we have used here, just as an example, are SRK2, SRKT, Hoffer Q, and Holiday. And they give really varied outcomes. So I think the consensus of the house is that we should go for Barrett's instead of all these. Or would you say that any other formula is good?
I would
Like,
definitely
But
consider a Barrett's
Barrett.
because Barrett's does very well for most eyes, except maybe very short eyes, in which case I think the Kane and Evo formulas have known to perform better. So I would definitely consider Barrett's.
Yeah, maybe you could compare with SRKT as well. Sometimes SRKT is also giving good results.
I agree. Yes,
Um,
SRKT
so
is
you can
also
just
very.
compare, you know. Then target refraction is something that we have to aim at. Maybe they will want to be myopic only rather than hypermetropic. That we have to keep in mind because myopes like to be myopic only. So that is another thing you can compare and contrast and probably come to a consensus between the two values.
Okay. So
Rupak,
here,
Rupak,
yes,
sorry, since you
please.
told a lot many fellows have joined, let us give them a take-home message that long eyes, let's make it simple. Universal Barrett 2, holiday or the ill. Some may not be access to Hill or Universal Barrett 2. So let us give a message that it's Universal Barrett 2 or holiday or Hill can be used for long eyes.
Okay. So here, like Kavita ma'am pointed out, actually the Barrett 2 is correlating very well with the SRKT as well. That is why I was asking if SRKT is still used by some or not. But but
See, if you want to you want to keep your eyes open and you know have a mind free, you can take out all the values from each of this formula and you can compare and contrast. That's what I do sometimes. So nothing wrong in doing that. Probably it just takes little more time.
This patient, particular patient, for SRKT
What is
was
the age of the patient, if I can ask?
I'm 59,
Okay.
and patient is minus 12 power, and then she came with for me like she want to be glass free. I told ma'am you're very high myopic, we can't give glass free. We tried, and no one makes power less than 6 for toric for this thing, multifocal anything like that. To give her option of monofocal toric, and that confusion was that for SRKT it was coming 3, and with Barrett's coming 4.5 B. So for the patient, after discussing with my seniors, I put 4, and patient first day post-op came 6 partial and N8.
Yeah. What was
So
the target emetropy, I mean, refraction in your
I
second
kept
formula where you got 4.5?
uh, uh,
4.5 was what was the target refraction?
no, for SRMM, for this thing, Prakhat, please put the Barrett sheet.
yeah.
Ashwini, not to
That
forget
is,
the macular changes of this
yeah.
patients, more than N8 or 6.6, it's the refraction, what comes on the first is very important.
So,
When
that is
we're
0.25, sir. That is 0.25.
then you have achieved it.
Yeah,
Vision,
yeah, exactly.
Uh,
But I think you compromise, I mean, you took a balance between the two, isn't it?
yes,
Three
ma'am.
here, there it was 4.5, and you
Yes,
went with 4.
yes,
So
ma'am.
I want to know what was the 4.5, what was the refraction there? Point,
So
can you tell?
according to Barrett, it was coming minus 0.21. And as per the SRKT, it was coming minus
So it was
0.75.
slightly myopic, right?
Yeah, but
4.5 is slightly myopic, and
mm,
you balanced it with 4.
yes, ma'am.
I would have done the same thing actually.
I kept
No,
closest to 0.
sometimes it's a gamble as well. Especially when we are doing with pediatric, no, it's a gamble for me. So that's why I'm asking these questions. I don't know, the refractive surgeons probably will be more perfect.
I think you achieved a good result, Ashwini.
It's a good,
Yeah,
good.
night should be because of macular changes, get the OCT done and see. Okay, if it is around 0.5, 0.75, I think you have achieved the target.
So, ma'am, one question, Kavita, ma'am. Ma'am,
Yeah.
like sometimes we operate small kids, like 3 or 4 year, 5 year kid with a corneal tear. We repair the
Yeah.
cornea, we remove the lens, we do until as required. And what's the ideal age and what's the best formula for such cases?
I usually take only SRKT only. But what is important is now that you're mentioning corneal tear,
Yes, ma'am.
you
Post
will
corneal
never
repair.
get a K reading there. It
Yes,
depends. If it's central, you will not get. And
ma'am.
even if it is eccentric also, you will not get an accurate K reading. Whatever is possible, you measure it. But I consider the other eye K. Now we don't know the past history of the child, right? Past history as well as past findings. If it's a known child, you can always go back and see the file. But if the child has come to you for the first time and there's a significant corneal tear and you have repaired it, I consider the other eye K reading. Of course, the chair time is to explain to the parents that we do not know what post-operative vision will be or visual outcome will be, and that the child might have to wear glasses. Either ways, you would be operating with guarded prognosis, isn't it? So I take the other eye K reading, other eye scan, and in the name of God, just operate.
And
But
time duration.
now the thing that you have to be cautious about in such situation is whether you will be, in case you are able to place the lens, whether you are placing it in the bag or in the sulcus. So you be prepared for both the kind of lenses. In the bag, you can opt for single piece lens. But if you think that on the table, you can't keep the lens inside the bag, then you be prepared for a three-piece lens, but undercorrect. About 1 to 1.5 diopter, you undercorrect because you're shifting anteriorly. Okay, that is one thing.
What's your opinion for putting three piece only in the bag in such case, traumatic eyes, ma'am?
Yeah, you can place three-piece lens in the bag. No harm.
No, ma'am.
Your sensor is a very good lens.
I mean, duration, ma'am, post corneal tear repair, how much should we wait? How much duration?
I wait for at least 6 to 8 weeks. But if, because the corneal tear has to heal, right?
Yes, ma'am.
So the tear repair has to heal. So I wait for 6 weeks at least. And if again I see the sutures, if there are lot of sutures which are very loose and the children they don't open their eyes, then you take a chance and then tell the parents that the same sitting you can examine the other eye, remove the sutures in the affected eye. In the other eye you can take the K reading and the scan.
Thank you.
There
So
is
we have
another
no
question.
choice. We have no choice. We have to consider the other eye.
We have a question from in the chat box. What best can be done if we don't have optical biometry in post ICL and LASIK patients? Any specific consideration for IL power calculation if the refractive surgery was done for hyperopia? So there are two parts to the question. One
Yeah.
is post ICL and LASIK without a IOL master, and the second is if a refractive surgery for hyperopia was done.
I
Yeah.
personally don't think the ICL will make too much difference, but definitely try to get optical biometry in post LASIK patients. You shouldn't go with ultrasound because ultrasound readings can be erroneous post LASIK. So you should try and get an optical biometry result. I mean, today's day and age, I don't think it should be so challenging. You can get a referral for an optical biometry. It's very important. And for hyperopia, what happens is between myopia and hyperopia, the difference is in the spherical aberrations. So I think many people recommend that in post hyperopic eyes, you ideally do not go for an aspheric IOL when you're implanting a monofocal IOL. You would go for something with no negative asphericity, but something that's more um, less aspheric, yeah, with lesser negative aberrations.
Zero is IOLs which are available from Care Group. You get Acrovision, then you get this Zeiss lens with zero. That will be the preferred choice for this post-hyperopic eyes. And as Soumya mentioned, I think without optical biometry, it's better not to risk the patient for cataract surgery post-hyperopic.
Okay. Okay. I want to know from Kavita ma'am and from the other panelists as well, and Jaya ma'am, how do you consider undercorrection in pediatric cases, like with respect to age? I mean, there are so many formulae that we know, but what is the practice that you are doing?
Mine is modified Dan et al. See, earlier we were looking because that was the only formula. But earlier when I started, it was based on axial length. So if the axial length is around 17 millimeter, I would put an IOL of 29 or 30. So based on the axial length, it was. Later we started using the Dan et al. Rule, where actually they are in undercorrecting by 20%.
Right.
Children around 2 years. And then about 2 years and till 8 years, they are undercorrecting by 10%. So I felt this was a drastic, shift. 2 years and about 2 years, but there's also growth occurring after 2 years. So
Right.
I have modified my this thing under correction here. For children around 2 years, I undercorrect by 20%. Then around 3 to 5 years, I make it 15%.
Alas.
And 5 to 8 years, it's like 10%. Even after 8 years, I am not going to make them emetropic. I do under correction by zero point 0.5 diopter, zero point 0.5 or 0.75 diopter. Because eventually these children are growing up to 20, 21 years. And I am satisfied by this.
Okay.
Yeah, I
Uh,
agreed with ma'am, whatever she said. And dance formula has given us very good results because many times, even now, getting the keratometry values in children is difficult. So, based on axial length, definitely works well. And after you do a series of cases, you come to know as to how much maybe you can learn from your previous mistakes that regarding the IOL power calculation for these children. But going by the recommendations of 20% for 2 years, 2 to 8 years, 10% is working well. We even tried what has been recommended by Vasada et al. And a little bit of under correction happened after that. So we shifted back to the Hans formula. Yeah, so works quite well.
What is important I have felt is if you are able to measure the K reading in office, in OPD, if the child is able to sit at the desk
and
AR,
yes.
ARK, table mounted ARK, if it's possible, you get it. I think now what I observe is even a child around 4 years, 4.5 years, comfortably they cooperate for ARK table mounted. Because what you do in the under sedation or in the OT, you may be able to get it or you may not. If you're lucky, you get it with a portable ARK. That is also quite reliable. I use the Nidec company one and I'm using it for quite some time. It's giving good results. What is important is to get an accurate length. So I will muster children more than 5.5, 5 years, they cooperate. Then we have to do the manual one only. But I do for both the eyes in all patients, in adult as well as pediatric. My point is that you compare whether they pay or not pay. You do A scan and AK in both the eyes and compare. There's
Okay.
always a chance of anisometropia. Because we are dealing with kids, we know that adults can
Yes.
have anisometropia. So all patients we do bilateral.
Okay. Point well taken, ma'am. A few more things that I would like to discuss is in pediatric cases, is there a cutoff for not implanting IOL, like ma'am had shown in her presentation as well? Uh, when would you not implant an IOL primarily in a pediatric cataract?
So the first and foremost, when I started off, I was implanting. When I started my pediatric, that's about 17, 18 years back, very challengingly, I would implant the IOLs. Even have custom made lenses from Excel company, no financial interest. We have made three-piece IOLs, custom made from Excel company, and I have implanted IOL in the back after doing good vitrectomy. But then later, if you start thinking, I started thinking this is the long-term effect of these children when they grow. One is, of course, the myopic shift. The other one is what will be the status of the IOL per se. So then I stopped implanting. For quite some time, I wasn't implanting for children less than 2 years. Now, that is not age is not the only factor that we have to consider. I always say that there are many other factors. That is, first is corneal diameter. Is very
But
essential because no matter how much you downsize, you ask the company to decrease the size of the IOL and then implant. All these are it's a kind of trial and error that we are doing. The corneal diameter, if it is less than 10 mm or 10.5 mm, it is ideal that we don't implant a lens. Then along with that, the considerations are that what is the anterior chamber depth. When we are doing the AA scan, better to note down the AC depth, lens thickness. These parameters we have to do it, and it is a routine thing for us, taking the corneal measurement, everything. So the AC depth is very narrow or shallow. Then placing the IOL in the bag. Our criteria, like the adult, is to place the IOL in the bag. The first criteria. So we have to understand what is the AC depth, whether the IOL is able to go inside, whether we can place it inside. And the third thing is the pupil dilatation. Many children know that the pupil, it doesn't dilate. Like some elderly patients, we have myotic people and rigid pupil. It's like that only. Both are two ends of the spectrum. Both we face the same situation. So these are a few important parameters where I will not place lens apart from age. If the child is above 2 years, definitely I will make it a point to place a lens, but keeping in other parameters into. If the child is more than 2 years and corneal diameter is less, I will not place a lens. I will not place a lens.
Okay.
Actually, you can leave them aphakic. They're better off that way.
Okay. Any more additions to what ma'am said from the panelists and from Dr. Kelkar ma'am regarding the decision to implant a lens in the primary pediatric cataract surgery itself versus deferring it for a few years?
Now, 2 years of age, bilateral cataract. Okay, let's consider unilateral cataract, then and 1 year old child. Then consider the refractive error of the other eye child. Then consider the refractive error of the other eye. Then consider and accordingly calculate. Been put an IOL and managed on contact lenses and have had better results than patients with IOL inside them. So it all depends on how well the child adapts to the refractive correction that you have offered and how well the parents understand the importance of wearing the glasses or the contact lenses and instituting the amblyopia therapy.
Absolutely. Prakat, I would like to just comment on this. Prakat?
Yes, sir. Please
Yeah.
go ahead, sir. Yeah.
So basically, in a country like India, the contact lens uses is very, very difficult considering the hygiene and other aspects, educational aspects. Hence, in general, we practice that we try to put the lens as much as possible in these children whenever they come across to us in our practice. The child can be as less as 2 months of age. The only parameter that already told by ma'am is 10 millimeters of corneal diameter and axial length of 17 millimeters. If it is less than that, I would rather refrain from putting an IOL and wait for the eye to grow to sufficient size. In addition to that, if you are planning to put an IOL less than 6 months of age, always do a PI. It is compulsory to do a PI. You should not miss to do a PI in children if you are planning to put an IOL in less than 6 months of age. Obviously, bilateral implantation, you can keep the child still hyperopic, but unilateral implantation, because of the chances of amblyopia, you tend to not keep it that much hyperopic. It will be just first hyperopic most of the time, in spite of the fact that patient may eventually become myopic later on. The only difference that I see from our Indian population eyes compared to the Western population eyes is that the eye growth of Indian children seems to achieve a very relatively adult configuration by around 2 years of age, almost reaching up to 90% of the age, 90% of adult size. So under correction that we normally do as per Dahan et al. Or other situations may not be true in Indian situation. Hence, a graded kind of under correction is warranted in children like these. So generally at RP Center AIMS, we used to follow a graded under correction published as per Dr. Kelkar et al., where we do 20% under correction initially less than 6 months of age, 15% under correction less than 1 year of age, and 2 years of age onwards, you reduce gradually to 10, 5, 4, 3, 2, 1. So basically, around 6 years of age, you are just keeping the child first hyperopic and let it be. And so, in most of the situation, you will land up just about right size. We have seen around 10 years of follow-up in these children, and it was decently good using this formula.
Right. That is why I was asking, because we follow that thing, and but still there is a lot of differences in the decision of putting the IOL. That is why I was asking ma'am what her experience is. Anyway, are there any other comments, Dr. Ganesh or Dr. Ashwini sir? Any panelists would like to say something? Last concluding statements. We are at the end of our session.
PI can be done in all patients in pediatric. Eventually, it gets closed, but it's okay. I think some fluid aqueous will be passing through it, even if it gets occluded. But I do PI in all the cases.
I think this was a great session on a very important aspect, which is the bread and butter of our ophthalmic practice. If we don't get the IOL power right, then all of the heroics of the surgery are they end up still meaning nothing. So a big thank you to Jay ma'am for joining us and sharing her insights, and also Soumya ma'am, Anand sir, and Kavita ma'am for giving your valuable time and comments. We are very delighted to have you with us, and we would like to have you with us in future as well. And lastly, I would invite everyone to the upcoming class on the next in this series on the 27th of August, that is on vitreoretinal interface disorders, and will be taken by the master, Dr. Ahmed Salam. With that, I think I would not stop you from your dinner and family time. Thank you everyone for joining us.
Thank you. It
Thank
was
you
a
for
good
the
session.
opportunity.
Thank you.
Thank you, Roop and Ashwini. Thank you.
Thank you.
Thank you.
Thank you, sir.
One and
Thank
all.
Thank you.
Thank you, ma'am.